Welcome to Between Two Ovaries, your go-to for all things women's health.
A lot of people just say like, oh, my vagina.
Yeah.
And
Yes.
that's
all
not,
of the above.
That's not your vagina.
No.
Well, it is.
We're here to cut through the confusion, bust some myths, and give you the facts straight from the experts.
You cannot still believe the amount of people that come to a gynaecology clinic saying that they don't look right down there and they need something doing about it.
We're keeping it real, bringing you honest conversations about topics that matter to you.
Everything goes back to the menstrual cycle. Yes, it's a low-risk procedure, but it's not a no-risk procedure.
From periods to menopause and everything in between, we've got you covered.
So whether you're here to learn, laugh, or just listen, you are in the right place.
As soon as I said it. So, hi, this episode is going to be on PAG and we have a special guest. So, welcome to Dr. Cara Williams, who's a consultant gynaecologist with a special interest in paediatric and adolescent gynaecology and also menopause. She's clinical lead for paediatric gynaecology at Alderhay Children's Hospital, which is the major children's hospital in Liverpool. She's a past DSD lead and she's current chair of the British Society for Paediatric and Adolescent Gynaecology. So, thank you very much for joining us, Cara.
Thank you for inviting me. So we're going to ask you a few questions and I'm going to start first. PAG, PAG, what is that?
So it stands for Paediatric and Adolescent Gynaecology. So it's essentially anything reproductive health for the paediatric and adolescent population. So I see anyone from birth upwards. The upper age limit depends on what you classify as an adolescent or a young person. It could be 18, it could be 25.
Can we go with 25, please? I'm still on it.
I also don't you think when you say PAG, because I've obviously attended Cara's clinics, not as a patient, I hasten to add, but when you say from birth, like it's just, I didn't understand that was going to be a thing. Like I imagined that you would be seeing people that had started the periods, or I don't think I understood that it was going to encompass literally from birth.
Literal babies.
Yeah,
True.
You don't see it in your training, you don't see very much of it, do you?
You just get thrown in.
You see predominantly post-puberty.
Yeah.
Yeah,
Wow.
and that was one of the reasons we wanted to cover it, because even within medical specialists who do obs and gynae, we don't know much about peds and adolescent gynae, which means that the general population will know even less. And then there's loads of things that are really, really common that you must see, that we'll talk about, that potentially are not problems. And then if people have better knowledge about what's normal and what's not normal, then hopefully that'll put their minds at ease if they are worried about something.
Yeah, absolutely.
I think to make people aware, we all went through obs and gynae training, but actually as part of your training tags...
We did not.
We did.
That.
As part of your training, you don't really do any kind of PAG if you don't kind of specialise in PAG. So you could go through training and potentially sit in one clinic or learn about it for exams, but actually never see any paediatric or adolescents patients.
And also equally for paediatrics, doctors who go through paediatric training don't do any gynaecology. So it's a kind of... It's
a very niche specialty.
Yeah, a niche area.
It is random. So if you're kind of a teenager and you go to Alderhay for some kind of in A&E or whatever, like it must be difficult, because if you're going with some kind of, I don't know, an ovarian cyst or something like that, who covers that? There's not many people, is there?
So paediatric surgeons will cover gynae emergencies.
There we go.
Oh, wow.
So they do a lot of the emergency ovarian cysts. So a query torsion, if you think the ovary's twisting, then the paediatric surgeons will see them, review them and take them to theatre.
Which is
So that's like a
obviously-
general surgeon, not like a
General
gynae.
paediatric
And
surgeon.
paediatric means children.
Yes.
And babies.
And babies.
Yeah.
Wow.
And adolescents, teenagers.
Up to 25.
Up to 25.
We're sticking with that.
There we go.
I'm an adolescent.
You're not an adolescent.
Well, moving
You might
on.
behave like one.
A young adult.
Who's that? We've also mentioned that you do DSD. What is that? What does it stand for?
So DSD stands for differences in sex development.
Okay.
So previously, years ago, it used to be called intersex. It then became DSD. There's now a movement to call it intersex again. So it can be either. And it's basically where an individual might have a difference or atypia in their chromosomes, which is their genetic makeup, or their gonads, which is their ovaries or testicles, or their anatomy.
Oh, wow, so it covers quite a
external
lot.
or internal anatomy from a reproductive point of view.
It feels like intersex somehow doesn't cover all of those things. Like, I don't know, DSD, how you would understand, I think, how people use intersex as potentially more of a slang word, like not kind of a medical terminology. I don't know. How come they're moving back towards that then? Is that just waves of change?
I think it's just some people who have a DSD prefer to use the word intersex.
Okay.
People don't. It used to be called disorders of sex development.
Yeah.
People like the word disorder.
Sounds bad.
Sounds abnormal.
negative.
Then we changed it to differences, but people don't want to be different either.
Yeah.
So it's intersex
difficult,
is
isn't it?
maybe a bit of a nicer word to use.
It does have a big impact terminology. Like we've talked about it when we did our laparoscopy episode, and when someone has essentially like no cause for their pain on laparoscopy, you say it's a negative laparoscopy, but that sounds like it sounds negative,
Negative.
it is, but it's not. And what we would like to like rephrase it is normal laparoscopy. So then when you go to a patient, you can say everything looks normal, which is actually a good thing.
Not everything looks negative.
Yeah. So there's a lot with terminology in medicine, and also like how that impacts the person's identity. So it's probably quite important to go with what the people you're
normal is
treating
good.
prefer.
Normal is good if it's normal.
Yeah.
But if you can't use the word abnormal because that's not normal.
Yeah. No, it is going to be
hard
hard
to navigate.
isn't it?
Yeah.
And is the DSD stuff, is that mainly up to 25 as well, or is that all
that,
through
that
like,
would be
PET?
lifelong. That would be
Okay.
lifelong. So we have a DSD team at Alder Hey, so we see them from birth onwards, and then depending on what aspects of their care they would need, they would then transition into adult services,
okay.
and then I would see them for gynaecology through their
Throughout.
adult life as well.
Yeah.
So there's good continuity.
Yeah.
So although I work in PAG, I work with adults as well,
Yeah,
who
just
I've
to keep
seen
it
in PAG that
confusing.
I then keep seeing.
That's really nice.
Into
That
adulthood.
you'll see them
So it is nice.
from the beginning all the way through to adulthood potentially if they still need like input from you. Yeah.
I
that's
don't think
nice.
there is continuity in any of the kind of gynae field, particularly as compared to you see the same patients all the time in a good way, in my opinion. Like people know you, your patients know you. You don't get that in gynaecology, and then in different parts of like in obstetrics, people are there for a short amount of time because you're pregnant or not pregnant, and then in fertility, it's a short amount of time because you want to get pregnant or you don't have that continuity. I think it's very it must be a very stable factor in a lot of people's life, which is a really good thing, I think.
Yeah.
Okay, so then kind of talking about what your job is like. So we know that you've got part of your job is a quite a niche area of gynaecology. What is your kind of normal week like? What do you do? What are your activities?
The day in the life
Work-wise.
of Cara.
Yeah.
Okay. So on a Monday, I'm based at Liverpool Women's Hospital, and I run a congenital gynae anomalies clinic. So that incorporates the DSD, but also anyone who's born with an anatomical problem with their womb. So the womb and the vagina and the fallopian tubes, we call the Mullerian duct. So it's a Mullerian duct anomaly. So it's either you could be born with 2 wombs or half a womb or no womb.
All of the different things.
So lots of
not a
different,
guarantee.
lots of different variations. And all the DSD patients will come through from Alder Hey into that clinic as well. Then on a Tuesday, I do a theatre list, which is quite often it might just be general teenage gynaecology needing an operation, or some of the DSD patients. And a Tuesday afternoon is either adolescent gynaecology, so that's the 16 to 20 year old. That's only 20, sorry, that
Damn, I'm not in
16 to
that.
20
I'm not even in that one.
with a general gynae problem.
Okay.
Or on alternate weeks, I do a premature ovarian insufficiency clinic. So that is for women who've gone through the menopause under the age of 40. We don't call it menopause because it's slightly different. It's more of a fluctuating condition, but it can happen from birth onwards. So I will see girls before puberty who haven't gone through puberty because their ovaries have stopped working. So at any age under 40, they have POI, or premature ovarian insufficiency. So that's that clinic. Then a Wednesday, I'm at Alder Hey, and that varies. I do a vulval clinic with the dermatologists. I do an endocrine gynaecology clinic with the endocrinologists, or a theatre list, or just a general PAG clinic.
So you have lots of work friends.
Yes, I do lots of multidisciplinary working, which I really enjoy. It's good. You get to see the other aspects of different specialties and what they do. Thursday, I work in Chester at the Nuffield, and Friday is all-day paediatric gynae clinic.
It's a real varied week.
It is
Yeah.
varied. It is.
Interesting when you said with dermatologists, because I feel like, again, that's something I'd never think of would be involved.
Yeah, so it's vulval skin.
Yeah.
So you can get eczema, you can get psoriasis, you can get lots of other inflammatory skin conditions on the vulva. So it's with a paediatric dermatologist, because lots of stuff we will see in gynaecology, but then we might see a rare skin condition that we've never seen before. So it's nice to have their opinion as well.
And so you mentioned you work with paediatric dermatologists, also paediatric general surgeons.
Yeah.
Who else do you work with? From
Endocrinologists, paediatric urologists, clinical health psychologists, and geneticists.
That
They're the
whole
sort
team
of
of people.
core group.
What do the endocrinologists do?
So they deal with hormones.
Okay.
So a lot of puberty problems, which I'm sure we'll go into later, will be related to hormones. So we do that work together.
That's great. So you must have a very busy Christmas night out. Everyone from different specialties.
Imagine all of the different
Sounds like at least 5.
I just think it's great because you always got like a friend to call to be like, what do you think about this? Or what do you
Yeah.
It's
think?
also really
I know,
nice
it
that
is
you're
nice.
not like pigeonholing into like, you know, someone has a vulval condition and they're age 9, so you just see a peds and adolescent gynae doctor. You're also incorporating other people who can give input into that.
I think
Working
holistic
together,
care as well is
which is
great.
really good.
Well, otherwise I might see someone and then say, oh, you need to see dermatology, and then they have to come back on another day to see another clinic appointment and wait, and whereas they just see us both together. So it works really well.
That's good. And so then basically you see a range of different people in your clinics, it sounds like, because I was going to ask you what kind of patients do you see, but that's probably a really long answer because you'll see
We'd
people
be here a long time.
Varied, well, kind of anyone with a gynae condition from birth up to early adulthood, we'll say. You could see them in
Still
one of your
very
many.
young at 25.
Yeah.
So I think we wanted to do a bit of background on what Cara does because I think it's just so far out of the norm from what we do. So I think from a general population, it would have been it's really good to understand what she does.
I'd never heard of it.
Yeah.
I'd never heard of it.
So as a little bit of a background.
Yeah, you're like, we're going to do an episode on PAG. And I was like, okay, PAG.
And we were like, hold that, we'll answer it later.
don't ask what it is.
We'll look it up, don't worry.
Yeah.
And then we wanted to talk about different conditions that Cara sees that are more normal, in inverted commas, that kind of can happen to a lot of different people, but people get freaked out or they don't know what they are. So we're not going into anything to do with DSD or intersex. We're going into conditions that are way more common and that Cara sees, but potentially maybe you don't need to see all of them because some of them could be sorted out before you've seen them, or some of them it's just a lot of reassuring that you have to do. So we wanted to go into those kind of conditions to kind of help people if you've got children or no children and kind of want to help with a bit of advice.
And also for people like, say for example, you are a dad and you are not a woman, you've never been a girl, and then suddenly you have a baby girl and you have to deal with all of the potential normal things, but to you they're completely new.
Yeah.
You might have lots of questions about what is
Even
normal
mums
in
as
terms
well,
of...
I feel
Yeah.
like we don't.
Yeah,
Well,
we
you
don't
don't-
remember being babies.
And you don't get the lowdown of everything, do you? Come on,
No.
like there's loads of stuff that people you only know it when you have them and then mention it to someone and then they're
Absolutely.
like, oh, that's normal. Hot flushes after you've had a baby. Yeah, totally. That's a normal thing. No one told me. Like, you know, like
You don't know
Learning
until you
something
go
new
through
every
it.
day.
that unless you know it.
Yeah.
So we're going to start at the beginning. We were trying to think about like what order to do these in. So we were going to start with neonatal bleed. So could you tell us what a neonatal bleed is, who it affects, and what it is?
So neonatal period is obviously when a baby is first born, and when a baby has been inside the womb, the baby is exposed to all of the mother's hormones, including estrogen. And estrogen can cause the womb to the lining of the womb to thicken up a bit, and then it can shed as it would with a period. And that's quite normal when a baby is first born, that they might have a little bit of a bleed.
So the baby having a period.
Yeah, like
Eleanor just being like,
the baby.
so the baby might have a little bit of a bleed within the first few weeks of life because of the maternal estrogen. So mum's estrogen that has come into the baby's blood while it's been inside the womb.
And obviously this is female babies. I
I
feel
can
like
see
to
that
spell
being
out.
Yes, sorry.
Yeah.
No.
Panic.
You'd be afraid.
Your baby's suddenly bleeding and you're like, what's going on?
Yeah.
So
How common is it? Do you know how common it is? Because obviously, some people
Sorry to
might.
put you on the spot.
Yeah, don't worry if you don't. But some people will, maybe not present to a GP, and therefore you don't actually capture everyone that it happens to. But is it a fairly common thing that happens?
So, I mean, this is actually probably one thing that more people do know about because we don't see very much of it in the clinic.
Okay.
So that must mean that
More people.
midwives,
Yeah.
health visitors, GPs are all kind of reassuring the
That's
mums
good.
when it
Maybe
happens.
it's something you get told when you've got a baby girl and they're like, by the way, this might happen.
This might happen. Yeah.
Yeah.
it's probably not, but it wouldn't be
Word of mouth.
When it happens.
It'll be
When
the
it happens,
afterwards, and
they'll
you're like,
say,
yeah, my baby's bleeding.
And I guess most of the time when
worry.
you've just had a baby, those first few weeks, you do have a lot of input from people like midwives and health visitors. So
Yeah.
you have lots of opportunity to ask questions.
Yeah.
Whereas later on, when you don't see someone as often, you might then be like, oh, I need to see Cara. Let's go and ask Cara this question.
So it's not anything to be worried about.
It's nothing to be worried about, no.
Okay, cool. The other common thing that we think must come to your clinic and also GPs and other places is like vulvovaginal irritation of young girls and babies. And again, we wanted to hear from you as a specialist, like what the cause is, what it isn't, and what kind of symptoms that might experience and how to treat it if it needs treatment.
So yeah, in our pre-pubertal population, so anyone who hasn't yet gone through puberty, the most common condition to come to our clinic is vulvovaginal irritation.
Okay.
Whether that's pain, itching, or just general irritation, or what it might look like. It's really, really common. So before puberty, girls don't make any estrogen at all. So the skin on the vulva, the labia are really tiny, thin little structures. The skin is very thin. The opening of the vagina is very close to the bottom. So it can get very inflamed quite easily. So the whole area can look very red. And that can make it quite sore and itchy. And it's really, really common. So it is probably the most common referral for an under 10 into the clinic. Quite often they might have tried a few treatments before they come. There's a bit of a misconception that if it's itching, it will be thrush.
We like a big myth, but we
yes,
like to bust myths in this podcast, so that's a good one. Yeah.
Thrush thrives in an acidic environment, so where the pH is quite low. But the pH in the prepubertal vagina is more neutral to alkaline, so thrush doesn't tend to survive. So you don't tend to get thrush. You can occasionally, but it's really uncommon.
Yeah.
Okay.
So sometimes they'll say, well, we used thrush creams and it got a bit better, and then we stopped using it and the symptoms came back again. And they probably get a bit of benefit from the moisturising potential from the thrush cream rather than the actual thrush treatment.
Right. Okay.
So we usually tell them to bin their thrush treatment because they don't need it.
Yeah.
And over 80% are not caused by an infection.
Right.
So a lot of people worry because it can be associated with a discharge, which can be green or brown. It can be quite smelly. So parents will worry that they've got some kind of infection in the vagina that's causing this irritation.
Right. Okay.
But usually if we take a swab, which is actually rarely required, if we do a swab, it's usually a bug that you would find in the bottom, which is spread forwards, or it would be a bug that you find in the nose, mouth or ears, because little girls' fingers like to be in their orifices here, and then they transmit the bugs down below.
We were all little girls once.
It's really common. And usually, unless you've got an obvious bug on a swab, you don't need to treat it with antibiotics.
And so is there kind of general advice that you'd give parents? Obviously it would be age dependent, but say you have a toddler or someone in nappies, is there any advice that you'd give to parents to try and prevent any vulvovaginal irritation? Or is it just a case of if it's there, then we'll give you some creams to try and prevent it getting any worse?
So the mainstay of management is moisturisers.
Okay.
Loads and loads of moisturisers. So we use a soap substitute for washing. So avoiding any soap, shower gels, bubble baths, they all dry the skin out and make it a lot worse. So avoiding any soaps, using a soap substitute, which is just a moisturiser with an antibacterial in, and lots of moisturisers to act as a barrier, and they can smother it all over the whole area. They're just really bland emollients that you might use for eczema or dry skin or something like that, but nothing with perfumes in.
Right, which is always what we say with vulval things. Like we did a whole episode on vulval care in adults.
Vulval health in children is exactly the same as in adults. Wiping from the front to the back.
No perfumes.
No perfumes.
No fresh.
Cotton onions.
Scented nappies.
No scented nappies, no scented wet wipes. Just they can put some of their emollient on some loo roll and wipe if the loo. Sometimes when they wipe it hurts. Sometimes when they go for a wee it stings because you've got concentrated urine coming out onto raw skin essentially. So I get them to put the moisturiser on before they go for a wee. So just pop it on so it acts as a barrier and then they can wee okay.
Cool. Is it something that they could buy over the counter, or do they need to see a medic if they're worried about this?
So you can buy a lot of the moisturisers over the counter. The one that we tend to use is called Hydromol ointment that you can get from Amazon, you can get it from Boots, Superdrug. The soap substitute, you have to go on prescription.
Okay.
So it probably does help. You can get some other vulval skin conditions which can present in the same way, so I think if they're concerned it's probably better to go and see your GP just to confirm that's what it is, to rule anything else out, and then get your moisturisers.
Sounds like a plan.
Perfect.
And you can see your GP for that, the prescription for the soap substitute. You don't have to come through to wait for a very long time to see it.
Absolutely. GPs can prescribe it. There's also the British Society of Paediatric and Adolescent Gynaecology, we call BritSpag for short. It's much easier.
We can put a list.
We have loads of patient information leaflets, and there's a really good one on vulvovaginitis.
Okay, there we go. We'll definitely put that at the bottom of the episode so people can easily access it.
So I guess another thing that, I mean, I'm not that familiar with, but maybe you see all the time, is like anatomical differences. And we did an episode where we were talking about sort of like the wall of vaginas and how different everything is, and vulvas, sorry, wrong word. But it's like, is there that same spread in...
Oh, I've
said your joke as well.
No, this is hilarious. This is what I said in one of the episodes. I was like explaining what the wall of vulvas was, and I was like, there's this huge spread.
And I just said
vulvas. And everyone else was like...
So is there still a big range in anatomy in young girls? And, you know, is there things that are normal and people shouldn't worry about, or things that maybe are a red flag?
So in the prepubertal population, the labia are really tiny, as I said before, and you don't tend to get as much kind of variation as such, but we do get quite a lot of girls referred with what's described as a lesion coming out of the vagina, or a skin tag.
Okay.
And essentially it's a remnant of the hymen. So the hymen is a thin membrane that covers the opening of the vagina. And when a baby is inside the womb, that membrane covers the whole vagina. It's complete. And towards the end of pregnancy, that membrane sort of pops open. To varying different degrees in different girls. So it comes in different shapes and sizes. And sometimes you can have a little bit that sticks out.
Okay.
And it's just a remnant of what was the complete hymen. So it looks like a tiny little worm coming out. And sometimes it's out, sometimes it's in. And that can cause quite a lot of distress for parents. But we leave it well alone. We just reassure that it's completely nice and normal and nothing to worry about.
We've covered a lot about the hymen before.
Have you?
So many myths. I love it.
Yes.
I just think it's such an interesting cultural thing that people have come up with so many different things that are not correct about it. But we've covered before the fact that it is a lot of people believe that it covers your vagina until you have sex.
Yes.
And that isn't true, and actually there is an opening before that, and that it varies so much in different people and varies after you've had been through puberty, and then again at menopause it can change, and that so many cultures sometimes rely on it to tell you whether or not someone's had sex, and it's completely unreliable for that reason.
When you were saying that about how in the start of pregnancy it's completely covered, sealed, I was thinking, how does the baby have their period then? But that makes sense now.
It's open. So also in that young age group, we might see a baby being born with slightly atypical genitalia.
Okay.
They would go through the DSD team. That's a whole talk for another day, so I won't go into that. But then as girls then go through puberty, start their periods, and then progress through their teenage years, we then see a lot of referrals for the labia. And girls not liking the way they look or not liking the way they feel, and being concerned that they look abnormal. And often you find, so there's obviously, I'm sure you've talked about this in another podcast, there's two different types of labia.
Yeah.
So you've got the inner labia and the outer labia. The inner labia develop earlier.
Okay.
And they tend to develop more towards the end of puberty and into teenage years, and they continue to change and to develop until at least the age of 18. So the inner labia develop first, and because the outer labia, which form kind of fat pads, they are quite thin and don't develop as young, the inner labia stick out relatively more, so they're more obvious.
And that's what worries
They
people.
haven't had that before, and suddenly they've got these labia that have sensations, and they feel unusual, and they don't like the way it feels and the way it looks, and there's often an element of asymmetry, so one might be bigger than the other.
Yeah.
And they don't like that.
But that
and
is all
often
normal.
It's all completely normal, normal. And there are lots of, you mentioned the Great Wall of Vagina. We, at Britsbag, we gave a £5,000 educational resource to a group who worked with Brooke, the sexual health advisory team, and they made a leaflet called "So What Is a Vulva Anyway?" And it's great. There's loads of line diagrams of anatomy. So what's the clitoris? What's the labia? What's, where's the urethra? What's the vagina? So it's a really nice little leaflet.
We'll need to find
written,
that as well.
We'll include that
it's
as well.
written in like terminology for a
Accessible,
teenager.
yeah.
So you can get it on the Britsbag website and you can get it on the Brooke website
We will
as well.
find it.
And it's really good. And then the other one is the Labia Library.
Oh,
Yes, we've
yeah.
looked at
Yes.
that one.
Also a good
we mentioned
one.
it in our
So
vulval episode.
I
Yeah,
spend a
it's
lot
really
of
good.
time going through all of them with the teenagers and just it's all reassurance.
Yeah.
But the other thing they do is a lot of teenagers will shave all their pubic hair off, so the labia are more exposed, and they wash with soap, so the skin's really dry, and then it becomes more irritated, and all of that irritation that you see in the prepubertal population, you then get in teenagers as well because the skin's just so dry.
Yeah.
Yeah.
So lots of emollients, moisturisers, and lots of reassurance.
Yeah. And I'm assuming that we're just saying out loud that these people do not need surgery, you never refer them for surgery, there is no place for surgery in this situation.
Absolutely. There is no medical indication for surgery, and quite some time ago the Royal College of Obstetricians and Gynaecologists and Britsbag came up with a joint position statement saying that vulval surgery labial reduction surgery should not be done in girls under the age of 18 because they're not fully developed.
That feels fair, yeah.
I don't think it's kind of done really on anybody now.
No, well, I tend to say to girls, it can't be done under 18. Even after 18, I wouldn't advise it.
Yeah.
And it's not routinely
Need to have a
done
look
on
in the
the
labia
NHS.
library.
Yeah. Sure, the only time
On
I've
the
heard
NHS
of
though, yeah.
it was in the Secret Life of Mormon Wives. I think it was one of them had
Oh,
it done.
really?
And I was sat there like, what on earth is going on? Why would you do that? So
We
that
have
was my
covered
first.
a bit about this in the vulval episode as
Yeah.
well, because obviously, the NHS wouldn't fund that treatment, but people can go privately, and there are people who will do things like labiaplasty and various other things for aesthetic reasons. But there's also, if you have surgery on your labia, then it can affect the sensation, which is really important to know. And also, if you have an element of kind of worrying what your body looks like, maybe a bit of body dysmorphia, if you have surgery, it might actually not make you feel any better. And that happens quite a lot. And then you're, in a position where you might have a bit of a complication after surgery, but you still don't think you look normal. So it's much better to be aware of the complete variety of how
that
different
that isn't
vulvas and
abnormal.
labia can look, and that it's normal.
Yeah. The Barbie doll is not normal.
No.
I've seen a couple of really badly broken down labia after labiaplasty because it's in a terrible place to heal. Like, genuinely, if you're thinking about...
You have to go to the toilet.
You have to go to the
You can't
toilet.
not.
You can't not.
And you're gonna have to wear clothes if you're not
got to have it
like
covered.
to get out of the house.
Yeah.
So, it's just in like a really
We
terrible
can't go
place
out
to heal,
vulva out.
and
Yeah.
you just think, oh gosh, what have you put yourself through? And now we've got this awful infection, and it's just
Yeah.
But unfortunately, in some private clinics, they are doing it on teenagers.
Really?
does not
It's
feel like the
scary, isn't
time.
it?
There's enough change going on. You don't need to be going through surgery.
Well, this is another thing
If you
that
don't
we'll
have to.
hopefully cover when we do our episode about education, about menstruation, about periods, but also about like anatomy and puberty.
Yeah.
If from a really early age, girls and boys are told and taught that there's normality and like differences in genitals, then hopefully as they grow older they won't feel like there's something wrong and then need to go down that route. But that's often not the case. And then because it's such a taboo subject to talk about female genitalia, a lot of the time
and I
it
feel
isn't
like
talked about.
at school they're not going to put the labial library on the screen for everyone to look at.
One of my
but-
colleagues who also does paediatric gynae, she went to a secondary school to do some teaching about genital anatomy. And they split the teenagers were about 14, 15, split them up into two groups. So the group of girls in one room, boys in the other room. And she showed them the labial library and said, which ones are normal, which ones are abnormal. And in the girl group, they were like, they're all abnormal. They're all abnormal, all abnormal. In the boy group, they said, don't know, don't care.
Really? And I was age like 14, 15.
Teenagers of some.
Oh, interesting.
That's iconic for boys.
I kind of wasn't
Don't know,
expecting
don't
that.
Yeah, because actually a lot of the time, like if it's something that you're not aware of, you've never talked to anyone about labia, you don't know what looks normal and not normal, and then you have sex, it might actually be the boy or the person you have sex with that makes you think that there's something wrong.
Yeah.
So it's really good that actually the boys didn't care. But also really important then for boys to also be taught as well as girls what's normal.
Yeah, this is important because
Yeah.
when you started saying that, I didn't know whether you were going to say they didn't show the boys, they just showed the girls, and I do think it's important that both people are taught.
Yeah.
Absolutely.
And then with puberty, so is there like a normal age or an abnormal age for people to start puberty?
So so girls could start making estrogen hormone from their ovary from about the age of 8 onwards. So any pubertal development, whether that's breast development, hair under the arms or down below, or periods, is not normal before the age of 8. So then we would advise that the parents take them to the GP for further tests. Anything above 8 is classed as normal.
Imagine it's just so young.
But it is still young.
Is it true
and
that Sorry, I'm going to go off a wee bit here. Is it true that the age that people are going through puberty is getting earlier?
It is, yes.
Wow, what?
Yeah.
People are more well nourished.
Oh,
Yeah.
really? Is that why?
Nutrition is probably the
Okay,
biggest
that's a
factor.
good thing.
Interesting.
Yeah.
I think.
So usually we would expect that most girls will have started puberty by the age of 13 and started their periods by the age of 15. So if you have a girl who hasn't started by those milestones, then they get
That's when
referred
you'd
for
go.
investigation. So 13 for puberty and 15 for periods.
Okay.
And when we say puberty as well, there's kind of different parts to it, isn't there? So there's usually, I don't know if this is right, I think it is, but you can tell me. There's the menstruation, there's the period, there's also breast development and then hair development as well.
Yeah.
And they come in a certain order, usually.
Yep.
One then the other, then the other.
Oh, what's the order?
So usually the first part of puberty is normally breast development. So you'll get a little bit of breast budding where the nipple becomes a bit raised and there's a bit of fatty tissue underneath it. And then the breast development continues. And that's because the ovaries are starting to make increasing levels of estrogen. And as your estrogen level gets higher, the breast tissue gets bigger. Also, at the same time, the uterus is growing inside. So the uterus starts off as a tiny little strip of muscle. And under the influence of estrogen, it starts to grow. So it changes from a little worm into a pear. So that grows, and then when it gets to an adult shape, which is normally when breast development is complete, you then start your periods. So you've got breast development is the first part, and then you'll have the pubic hair and axillary hair under the arms, growth spurt, and then the final part of puberty is the periods. Sometimes it can be what we call discordant, so it might happen in a slightly different order. Sometimes you might get a 9-year-old who has a bit of bleeding, but it's just a one-off, and then they start their periods later on.
Say if your child doesn't start one of these phases, or you just haven't noticed any like pubic hair, or you've not noticed any breast development, is that something that you'd be worried about? Because obviously you say 15 for period and 13
So
for
13 if you've got no breast development.
Would you come speak to someone? Or?
And then you'd normally go and see a GP, and then they would probably refer in to see either gynae or endocrinology.
I was going to say endocrinology does cover a lot of that kind of stuff as well, doesn't it? Because they're very used to inducing puberty. So if someone came and they saw you or endocrinology, they came and they'd not started their periods, where would you start with regards to that?
So they would normally come to our joint clinic.
Yep.
So we see them together, and we would do lots of different tests to try and find out what's going on with their hormones, what's going on with their anatomy, so what caused their lack of puberty or lack of periods. And then if it doesn't seem like they're going to go into puberty themselves, we will then bring it on with some patches of estrogen. So HRT patches, just the estrogen only patches, and we get them to cut them up into small, like a quarter of a small,
it's
and
like
then
little plasters.
it's like a little plaster that they put on the top of their leg, and they change it twice a week, and then gradually over about 2 or 3 years we increase the dose of the estrogen that they get, so that mimics the natural puberty.
Interesting.
That's clever. I like that.
And it's like a joint effort, isn't it, with you and endocrinology, kind of do it together.
Yeah.
But yeah,
Because you don't want to go too quickly, you don't want to go too slowly. You want them to be in keeping with their peers, so their friends at school. They don't want to be way behind and not have any breast development and not have their periods when all their friends do. Yeah. But also if you give them too much estrogen too quickly, you can get abnormal breast development. So it's about doing it at the right rate for them.
Yeah.
And once they've had the patches for like that 2 or 3 years, you said, will their body then make its own estrogen, or is that something they're gonna have to be treated for life?
It depends on the underlying cause, but the majority will have to then have estrogen. We'd usually say until the age of 50, which would be the average age of menopause. And although they need that estrogen to get them through puberty and give them periods, they actually need it more for their bones and for their heart, so for just general well-being, to keep them healthy.
Okay.
And so for a girl's first period, what should parents expect? What should the girl expect? What's going to happen?
So again, it can vary. So it could just be a bit of light spotting. It could be a full-blown period that's really heavy and lasts a couple of weeks. So it can vary. Now, when the periods first start, although the womb has grown big enough and it's the right shape, so it's mature enough to have periods, often the brain and the ovaries and the womb don't really talk to each other, so you don't really get regular periods to begin with. And you basically need the ovary to be releasing an egg every month, because that sends a signal to the womb to have a bleed 2 weeks later. So if you're releasing an egg every month, you'll have a period every month. But most cycles, more than 50% of cycles in the first couple of years aren't associated with releasing an egg. So the womb just has a bleed when it feels like it. So that could be 2 weeks apart, it could be 3 months apart. And those, we call them anovulatory cycles when you're not releasing the egg. And they can be quite irregular. And the bleeds that they have can be very heavy and prolonged.
It's kind of just like how at the end of your reproductive life in perimenopause, you have a similar thing where because we've covered an episode on like HRT and menopause, where the brain and the ovaries aren't communicating very well, and they might be like, okay, release an egg, and then not for quite a long time, so you can get quite erratic, sometimes heavy periods. It's quite interesting that it happens at the beginning as well as the end.
It's like a slow
They're
get used
exactly
to
the
it
same,
and then
just
a get
in reverse.
back when you're used to it.
Which is why I probably do both.
Is there anything in a first period or the first start of the period that you'd be like, right, this is abnormal, you should maybe speak to someone?
I think if it's going on for a long time and it's really heavy, so if it's lasting more than 10 days, or if it's really heavy, or if the girl is feeling lightheaded or dizzy, or, then you probably need to get some bloods done to check that she's not anemic, because they can, because if the bleeding is really heavy, they can occasionally, not very common, but they can become anemic or iron deficient.
And if that carried on, so you're saying at the beginning it can be all over the shop with your periods, if that carried on and they're now 13, 14 and they're still having periods all over the shop, what would you do for that patient?
So if it's been going on for more than 2 years, then we'll start to think about doing some hormone tests to have a look to see if there's an underlying hormone imbalance that might be causing their periods, like an underactive thyroid or polycystic ovarian syndrome or premature ovarian insufficiency, as we mentioned before, where they've gone through the menopause early.
we wanted to cover a little bit about PCOS as well, because we have done an episode about polycystic ovarian syndrome in adults, but obviously it can affect teenagers as well. And we wanted to know if there's any like big differences in how teenagers with PCOS might present, or any differences in the management.
I think because
really.
the guideline goes into it, doesn't it? So like the big guideline on PCOS discusses actually about kind of teenagers and how you should and shouldn't diagnose and what you should and shouldn't do. So we thought it'd be interesting to have a little chat about PCOS and your thoughts on PCOS and like adolescence.
So it can be more difficult to diagnose in teenagers because teenagers have multifollicular ovaries. So their ovaries are usually slightly more bulky, and when you scan them, they have lots of black dots on them, which are all the follicles. And that's what you're looking for when you're looking for polycystic ovaries. So if you scan them, you'd overdiagnose PCOS. So we recommend that you don't use ultrasound in the diagnostic criteria if they're within 8 years of their period starting.
Okay.
Wow, that's quite a long time.
Yeah, because it can take a while for things to settle down. So we can only go by their periods and whether they've got... we can't use acne either because... teenagers get acne.
Puberty, isn't it?
It's a great time.
So
what can we use?
We use irregular periods, excess hair growth in a male distribution, so upper lip, chin, neck, chest, back, arms, something like that, and their blood test. So we measure their male type hormones to see if they've got raised levels of them.
And do they have to have all three, or...?
So one of the three would be the scan. So they have to have 2 out of 2. So the
two.
periods and either the excess hair growth or the bloods.
Okay.
As it would be with adults.
Yeah.
And when people come and they've got their heavy periods, just as we've kind of discussed with when we see adults with heavy painful periods, we've said that there could be underlying conditions, but we have discussed about that you would treat the symptoms rather than potentially go in and operate straight away, because if we can get people's symptoms under control, then it's kind of a lifestyle that we're treating rather than a condition per se. Is that the same when you see your teenagers or your adolescents?
Yeah, absolutely. So for heavy periods, it's very, very, very unlikely to be anything abnormal.
Okay.
So we might do an ultrasound scan if we think they might need a bit of reassurance, but actually we're not going to find cancers of the lining of the womb like you would be looking for in a adult woman. So usually that just needs medication to manage the periods, whether that's to regulate it with the contraceptive pill or just some medication to make the actual periods lighter. When it comes to painful periods, you can have anatomical problems, like I mentioned before, born with 2 wombs or one womb that's a bit blocked or something. So there might be a blockage of the blood coming out, which will cause a collection of blood and give them significant pain. So if there's very painful periods from the outset, then they need a scan just to make sure that there isn't an anatomical problem. There's a lot more awareness now about endometriosis, and we get a lot of referrals for girls with painful periods, query endometriosis. Unfortunately, the only way to diagnose it is with the diagnostic laparoscopy, which you've done a podcast on already. But I quite firmly believe that we shouldn't be rushing into doing surgery on a teenager who has painful periods just to get the diagnosis. We know that they can have endometriosis from the outset, so it does occur in teenagers. It's not no, you're a teenager, you don't have it.
It can possibly be you.
And especially if they have a first degree relative, so a mum or sister with endometriosis, they're 7 times more likely to have it. So if they have symptoms that sound like it, particularly if there's a family history, I say to them, look, there's a strong chance you do have it. Let's treat you for endometriosis, treat you as if you have it. We know that the vast majority of teenagers with endometriosis will have stage 1 disease, which is the mildest in terms of how much there is that we see at laparoscopy. And that should be treatable with hormones. We also know that the younger you are when you have your first laparoscopy for endometriosis, the more laparoscopies you have in your lifetime, the more scar tissue you have and the more complications you might have. So I think it's really important not to rush into doing it. But I do understand that it can be really frustrating when you don't have that diagnosis because you want to explain why you can't go to school and you want people to listen. And I always say to them, you know, your pain is real. You have significant pain, and we'll often write to the school to say, this girl is under our service for really debilitating periods that we are managing. Please allow them a toilet pass, or you know, so you know, it kind of validates their pain without necessarily having a label for it. And so we tend to try and treat them with hormones, and ideally just try and stop their periods completely.
As a question, you say that so these heavy periods you can treat with hormones. Do you ever get any backlash from parents about not wanting their children to have hormones because it might encourage them to partake in sexual behaviour? Yeah,
so you do. You will get some parents who are a little apprehensive about using contraceptive pills when they're, say, 10 or 11, or even the older adolescents. So there's lots of reassurance there that it doesn't make them more sexual and want to go and have sex.
And that it's like a hormonal medication, not
and
for
it's
contraception.
the hormones that their body's making anyway. We're just giving it in more of an even keel. But I do find there's a lot on social media about contraceptive pills being dreadful. So you actually find now it's more the teenagers that don't want to go on it.
It's hard.
You've got the mums who are perimenopausal and banging on the door for HRT, but the teenagers do not want to take the contraceptive pill.
We've discussed this at length, saying about this hormonal detox and not being on hormones, want to know what their body's doing, and I'm all for it if that suits you and your periods are okay and you've not got any problems. But for the masses, not having periods is amazing. Like,
especially if
I haven't
Absolutely.
But
I think also
I totally with you. Like there is like a generational thing.
I think
now.
it's like actual hormone hate.
It's not just
hard,
like
it's hard to then, you know, if that's the treatment that you know will be the best for that adolescent, in terms of like they are missing school because for 2 weeks out of the month they've got a really heavy bleed and they're in lots of pain. That's going to impact the rest of their life because it's going to affect their school grades, it's going to affect their career choices. And if the treatment for that is a hormone and they have watched a TikTok video that tells them that they're awful, you shouldn't take them, it's really hard to like break that down and try and change their opinion.
Totally.
I mean, I think as well, younger people are a lot more influenced by these things. They see on social media, it's like prime age.
I think they worry, a big worry is that it will make them put on weight. So I always say there's no evidence that the hormones will make them put on weight. They might feel more hungry. If they eat more, they'll put weight on. But the pill itself will not put weight on. They worry that it might affect their future fertility. But I kind of get around that by saying, well, if you've got really painful periods, you could have endometriosis. And without hormones, that endometriosis could get worse, which then could affect your fertility. So actually being on a pill early could protect your future fertility. And usually if there is a concern about endometriosis, they might then be more happy to take it because they know that that's going to help them from a future fertility point of view.
I think it's difficult because there's so many unknowns, isn't there? And you were saying kind of operating on potentially stage 1 endometriosis. We don't know if that would help at all. And we know from a lot of studies that 6 months, a year down the line, people are no different than before they had the surgery. So I think if we had something telling us that is a good treatment that would cure / help / give you 5 years of being free of pain, but we don't have that. So I think treating the symptoms until we get something that is actually treating the cause, which I think surgery in a lot of cases doesn't, it is what we need to be kind of focusing on, and looking for other treatment options, obviously, from a research
and
point of view.
we do in teenagers use the Mirena coil quite a lot. So we start off with the contraceptive pills. If they don't work for one reason or another, they get side effects or they have breakthrough bleeding on them, then we go for a Mirena, which works brilliantly. But we wouldn't put it in a wake in a teenager who's never been sexually active. So it gets done under general anaesthetic.
That seems fair.
That's an important point.
We've had big episodes about the Marina, haven't we?
But I think that's really good to know because I think that's something that people would worry about.
Definitely.
The patient and the patient's mum,
Oh,
or dad, or whoever, because I think they would be. I know there's a lot of stuff with the hymen which is absolute nonsense, but with regards to going somewhere and having a speculum when you've not been sexually active, that's a big step.
Yeah, absolutely. Yeah.
And we've had
It's not a
discussions
reason to
before
not.
where when people come to your clinic, you don't routinely examine them. That's not a thing that you do
No.
at a paediatric gynaecology clinic. Like
No.
you don't, because it's not fair. It would be way outside the abnormal of what would happen.
Yeah, and we talk a lot about how scary and kind of uncomfortable it can be as a woman going for something like a smear. You're worried about, especially if it's the first time, you're worried about like what you look like, what people will think.
even just
going
having a
there and doing that.
speculum.
So as a teenager, that would be 10 times worse. So
And if you've watched your TikTok video,
yeah.
If you've seen any of the smear hate, you're terrified.
it's not going to be
So it's
a
good to know that you
No.
won't necessarily need that. When you come to
So we
see.
do reassure them when they
Yeah.
come in, you're not going to have an internal examination.
Yeah, that's good.
We wouldn't even need to do any examination if it's just heavy painful periods or irregular periods. It's only if there's a vulval concern that we might need to have a look.
Yeah, and that's just looking from the outside anyway,
Yeah.
isn't it? It's very
Yeah.
different to a speculum.
absolutely.
Yeah.
So all reassuring stuff.
Yeah.
Yeah.
Is there anything else that you think that we need to cover that we've not covered before we get into our myths and questions? Anything that you see in clinic often, or something that you reassure people about a lot, that you're like, I need to just have this on this right now? You don't have
I
to.
think, no, we didn't talk. We talked about neonatal bleeding.
Yep.
And we talked about puberty and when bleeding should happen.
Yep.
But we also get quite a few girls coming with prepubertal bleeding, so
Okay.
bleeding before they've gone through puberty. And that is something that we do need to see.
Okay.
So before age 8? Or...
Before aged 8,
Yeah,
So
okay.
bleeding before you'd
And with no
expect
other
to
signs of
normally see it.
puberty.
Yeah.
And what could, just as a very basic top, like high level, what could be the causes of that?
So we would want to rule out early puberty. So sometimes it can be the first sign of a girl going into puberty early. We'd want to rule out any infection, and we want to rule out whether there's anything anatomical inside the vagina or the bladder that might be causing that bleeding. So we do ultrasounds, we do bloods to check the hormones, we do x-rays of their wrists to see what how their bones are developing. to see if
it's like,
there's
why
any
have we
kind
jumped
of-
up here?
see their bone age.
Okay.
So if someone's 5 and their bone age is 9, then they're more advanced. So that could suggest that they're going
Which
to
is
puberty
potentially
early.
not a good thing.
I know, I'm like advanced in a good way.
So then usually once we've ruled everything out, we then would do an examination under anaesthetic. So if you've got an adult woman who has abnormal bleeding, she'll go to the doctor and have a speculum to check the vagina and check the cervix, but you can't do that in a 5-year-old. So we'd put them off to sleep and just pop a little camera just at the opening of the vagina just to have a look to check that the vagina and the cervix are normal.
And they've not put anything into their vagina.
And that they haven't yes, because we do get foreign bodies.
Oh dear.
Injury or anything.
Or injuries, or, you've obviously always got to have safeguarding in the back of your mind and think, has this child been sexually assaulted? And is there an injury somewhere? So that's got to be the first sort of port of call, that they need an external examination to check and an assessment. And then ruling out everything else. If everything is completely normal and it's just an isolated bleed, we call it premature menarche. So menarche is when you start your periods. Premature is early. So we think it's like a period. It's come from the womb. And it may just be that the ovaries have just woken up a little bit.
Done a little shot.
Fired off a little bit of estrogen, and the uterus has been quite sensitive, and then it's shed the lining and they've bled. And usually it's a one-off, and then we'd expect puberty to happen at the right time.
Yeah.
Hopefully.
Yeah, fingers crossed.
So usually we move on, have a little myth section, have a little question section. If you would like to hopefully be involved in these.
So our first myth, which I think actually leads on really nicely from what we've just said, is that children just should not have gynecological issues. They shouldn't need to come and see you ever at all. And if they do, that's obviously a sign of, poor care, poor treatment, poor health. Thoughts?
Yeah.
No, hopefully. That's not the case. Girls have vaginas and vulvas. They have wombs, little tiny ones, and so they can have issues with them. And it's usually, as we've discussed, it's all normal and nothing to worry about. but it is best to get it checked out just in case.
It fits with our theme of like general myths about gynaecology are that it is the woman's fault. Like she's done something to cause the endometriosis or
Emphasis
cause
on
her...
myth.
Yeah,
Not
so
real.
not true for children either, which is nice.
Another one is young children can't get thrush. I know we touched on this at the start.
So
but
it can occasionally, so you might do a swab and it shows it, but usually it doesn't thrive in the more neutral to alkaline vagina.
Okay, the next one is the idea that if you have any gynecological issues as a child, you're just probably going to have fertility issues, you know.
No.
Good, nice and
Absolutely
easy.
sometimes it's just a simple no.
That's all we need. Perfect.
I think as long as you found out what it is and it's not something that would translate to being
Most of the
adult.
things that we see, we do spend a lot of time saying that this probably isn't going to have an impact on future fertility.
That's good. That's reassuring, I think, for a lot of people.
A lot of the times that they just need reassurance, and we do that in gynae clinic and in gynae emergency room and at hysteroscopies.
Yeah.
And we do that a lot, I think, spending a lot of our time saying, you might have had a scan that looked abnormal, but I promise you, by eye, this is normal. You might have had this issue and it's annoying, it's whatever, but this can be treated very straightforwardly. We need to just do X, Y. Like, there's a lot of reassurance because I think because a lot of it is just not talked about, is it?
Yeah.
Like,
Yeah, totally.
until it happens to you or it happens to somebody you know.
Or you listen to our podcast. Another one is if there's no pain, there's no problem. So
In terms of like
Heavy
periods.
periods?
well, I think it's interesting because, like you mentioned, with the early period that a child might have before they go through puberty, there's no pain there. But then, is that a problem? You get them to
you
come
would
check.
look into it, wouldn't you?
Yeah.
Yeah, I think if there's it doesn't necessarily to have pain, because you do see people with really, really heavy periods, don't you? They
And they're not
debilitating.
necessarily painful.
No.
They might just be flooding completely,
of-
but
yeah.
not too many cramps.
And it's stuff where like they're like covering it up so nobody in the family knows about it until at one point when they're like, why is this bedding in the wash?
Or mum realises that she's buying pads yet again.
Yeah.
Because they've all
100
disappeared.
pads a month.
Yeah.
Yeah. But it's that education again, isn't it?
Yeah,
And
of
kind
what might not be
open
normal.
dialogue with your parents and yeah.
I think that leads us really nicely on to the first question then of what can parents do if they notice their children are struggling with periods or puberty? Sort of, what can a mum and a dad do?
Yeah, so I think if your child is struggling, take them to the GP. You know, see what options there are. It might just be a matter of take a tablet when you're on your period to make it slightly lighter or make it less painful. But I think the first port of call is to go and see your GP and see, is that normal or abnormal, and what can you do to help? Because you want the girl to go to school, you want her to go out with her friends and have fun. You don't want to worry that she's going to flood through everything and stay in bed while she's on her period. This is something she's going to have till she's 50. You know, you want to kind of make it as good an experience as possible to make them better.
Having that education and that open dialogue from the beginning, kind of that you are talking to your children about what their anatomy is and what it does and what periods are and that they are a normal thing. And if you are on your period and your child comes into the toilet, that you're not pretending that you're... Because I've seen and read things where people have been really worried that their mum's like bleeding to death because they've seen like a tampon in the toilet, or because they don't know. So I think when they get to an age where you think that they should know about this kind of stuff, or they're old enough, or an opportunity arises, don't shrink back from it. These are normal things. You're not telling people really abnormal things. You're telling them about periods.
And when they start learning about it in school, have that open dialogue at home. So what did you learn? What do you think of that? And maybe expand on what they've learned in school.
I found it interesting. I saw a video recently where people were talking about what they used to call their vulva when they were younger, like what the word would be. And
hundreds of different
there were
words.
so many different ones. There was like their fairy, their flower.
Front bottom.
There was front bottom.
Mary.
Mary. Yeah, there were a few really random ones.
I've never heard Mary before.
There was a
that's
few
a Liverpool
random
thing,
woman's
because I haven't
names
heard
just
it
thrown
before
in.
coming to Liverpool.
No,
But that
I
was
think,
interesting.
People like frown when you actually call anatomy by its actual anatomical
But
names.
for boys, you'd just be like, this your willy.
Yeah.
I feel like they don't
Yeah.
go much further than that, do they?
When my kids came home from school, when they must have been like 6 or 7, and they were like, so boys have a penis, girls have a vagina. And I was like, that on the outside is not a vagina.
You're like, good try.
You'll get this right.
They
It's a
do have
vulva.
a vagina, but they also have a vulva. Yeah.
It is funny though, because I think obviously we're used to hearing these words, but my husband, we were out with some kids the other day, and one of my friend's daughters was like, don't do that, you're going up my vagina. And Emil was like, don't say that. She was being hyped up by something. It was an appropriate use of the word.
Yeah.
But I think
just
when you're not
as a shock.
used to using that, because I'm sorry, but me growing up, we definitely didn't use vagina and vulva in my house. Like, it wasn't a thing.
My
that
mum
we
was a
used.
midwife, so we definitely
So look at you now.
Look at me now.
It made me laugh on this list was both Fifi and Lulu. My cousin's cats are called Fifi and Lulu. Where have they got these names from?
Brilliant.
Oh, there we go.
You have to tell them what it really means.
I think it is changing. I think a lot of parents and like schools and general population are starting to use the words more correctly, like vulva and vagina. And I think the more that happens, the less stigma there'll be associated with it. Because if you are calling it a flower, then that implies that it should be
They were all very
renamed
feminine
for some
names.
reason. Yeah, like there's a problem with it.
I think it's better to be anatomically correct,
Yeah.
and then you know what they're talking about from the beginning.
Definitely.
And then another one. So, what can I do about my daughter's recurrent UTIs? Is it all hygiene issues?
We haven't really touched on UTIs, have we?
Yeah, so these generally tend to go to general paediatrics rather than gynae, but we do see quite a few that will come, and it turns out to be something like vulvovaginitis, and they're not actually having proper urinary tract infections, but they're having stinging pain when they pass urine, and it's thought to be a urinary tract infection, but actually you need to get a proper sample from the lab that tells you there is a bug here and this is what it is. So if you think your daughter has recurrent urine infections, it's really important. Every time they have the symptoms, you need to get a sample and send it to the lab to confirm because we need to know what the bugs are that it is causing it each time. And then if there's good evidence of recurrent urinary tract infections, then they need referral to the paediatricians to check their kidneys and their bladder and everything.
Okay.
So this one's a bit different, but at what age does vaginal discharge become normal? I feel like we've not really touched on that.
No, we haven't discussed this because we've discussed a lot of times that we're like, vaginal discharge is normal.
So normal, it's so healthy.
Get with the program. It does different things at different times of your cycle. You would be lost without it in some ways. Like you need to understand that vaginal discharge is normal. But no, we haven't.
At what age?
So we know it's normal definitely when you are having a cycle, a menstrual cycle, because it is part of the menstrual cycle. Is it normal for girls to have discharge before they have their period?
So it can be.
Yeah.
You can have discharge from a baby onwards.
Okay, so
again, as a baby, similar to the neonatal bleeding, they might have a discharge because of the estrogen they've had
exposed to,
from mum. Vulvovaginitis quite frequently causes a discharge. As long as it's white or yellowy, it's probably nothing to worry about, but it can even be green. But it's actually really quite common.
Okay.
And nothing to worry about most of the time.
So we're still big fans of discharge.
I think if a prepubertal girl has an abnormal smell or an abnormal colour, or it's quite profuse, there's a lot of it, then you probably need to see your GP to see, does it need a swab? Is there an infection? Is there a foreign body? Something like that needs ruling out.
Another one, what should I do if I notice my daughter has a fused labia?
So fused labia are, again, relatively common in the prepubertal group. And it's because, again, of the lack of estrogen and the labia being so tiny. Usually it's associated with vulvovaginitis, so there's some inflammation of the skin that then just causes the two little skin flaps to stick together. So it's nothing to worry about. Often we will get referrals for girls where the referral states they're coming because they have no vaginal opening. And it usually presents itself around about the age of 2, and often that can cause a lot of parental anxiety, and they can't understand why they never saw this when the baby was born. Why have they only suddenly noticed this at 2 years of age, that their daughter has no vagina, and obviously the implications of what that might involve. So there's often quite a lot of parental anxiety about that, and sometimes if you have a look, you can see a little opening, so you can see a little line where they've actually joined together. But sometimes you can't see a line and you can't see an opening. So we normally would then see them at that point just to give them that reassurance. But we can generally assess and tell that it's labial fusion rather than an absent vagina.
Okay.
And what would you need to do with labial fusion?
So we treat it in the same way as vulvar vaginitis, with lots of moisturisers, no soaps, no shower gels, nothing perfumed, lots of moisturisers, and usually they will open up gradually by themselves. If there's any urinary problems, so if there's a lot of what we call post-void dribbling, so they go for a wee, they sit down, they do the wee, they stand up and they dribble because the urine's collected behind the adhesions and then it dribbles out later. So if there's any post-void dribbling or there's any urinary tract infections from reflux, then we would sometimes use a little bit of estrogen cream just to help it to open. Followed by lots and lots of moisturiser.
All of the default.
But in almost all cases, it will open up by the time they go through puberty and make their own estrogen.
Perfect. This one I think we have touched on a little bit with like people are asking if they've got daughters, can they really not have any bubble baths at all? Because I mean, you see all the soaps that are aimed at kids. There's so much
The
fun.
mermaid ones.
Yeah.
I remember that one that had a big mermaid.
I swear I had like foam soap as a child that looked like shaving foam. Like, can these kids, should we just totally avoid these things with little girls, or like?
If you're a girl in my household, it's an
Absolutely
absolute no.
not.
Bath bombs, bubble baths, they all go.
I mean, age 12, the best thing in the world was Lush. It would be like you would go on a day out to go to Lush. That would be like
Never
presents
mind age
for
12,
everyone.
I still love going to Lush, but then
But we're getting
bubble
advice
baths.
not to.
It's a bit intense.
Yeah,
So yeah, probably best to avoid those kind
Best to
of things.
avoid.
Yeah.
Okay.
in my opinion.
I think we've
That's all
covered
of
all
the
of our
questions.
questions,
Yeah.
Sarah.
Fab. Well, thank you for coming. It's
Yeah.
been great to have you.
I feel like I've learned so much.
No, same.
I'm still baffled that babies have a period. Back at the time.
Not all, but
Yeah,
they can.
can,
Yeah.
sorry.
I thought you were going for I'm still baffled that I'm an adolescent.
That's your biggest learning
Stuck on
today.
Yeah, okay, so a quick disclaimer, everything that we've discussed today, they're our own opinions, they shouldn't be affiliated with where we work, and don't take anything that we've said as personalised medical advice.
Yeah, so if you found this episode interesting, if you learned anything like Eleanor and I did, please leave us a review and remember to subscribe wherever you get your podcasts.
It might seem like a little thing, but if you give us a 5-star review, it pushes the podcast out, and we just want to break barriers, bust myths, and get everyone access to proper good information.
And we really want this episode and the podcast to reach as many people as possible, so if you want to be a part of that ripple effect, then please hit the like button.
And make sure you're engaging with our content and following us at Between Two Ovaries on all our socials.